Good evening. So let me walk you through this session, which is sponsored by Microport, and we will be discussing a new device for closure of left atrium appendage. So it's a great honor to co-chair and lead this session with our speakers and discussants, Krzysztof Milewski, Luis Nombela Franco, Dr. Fenghua Ding, and Juan Pablo de Brahi. So I think that the outline of the session is a short introduction on what the new device is, how it's handled, and what are the criteria. Then some hints about anatomy of the LAA, which can be treated with this device, and then we'll move on to showing a case and having a hard team discussion also with you, I hope. So if you have any question, just raise your hand, use the app, we'll be able to answer your question. So without further ado, you're welcome to introduce the anchorman device.
Okay, thank you. Good afternoon, ladies and gentlemen. I'm Dr. Ding from Shanghai Regional Hospital of China. It is a great honor to be here to give a little introduction of this Ackerman from Microport CardioFlow, a new left anterior appendage closure device with clinical and procedural advantages. Do not have any potential in conflict of interest. So to begin with, I'd like to remind you of device migration and embolization in the real-world practice from the NCDR LAA registry of 120 procedures. The in-hospital DME is about 0.07%, among which 46% patients need a surgical retrieval. And post-discharge DME is 0.06%. Although the percentage rate is not very high, but we still remember the prognosis of DME patients can be poor with a high mortality rate, with 14% in hospital and 3.7% in post-discharge. So for this various anatomy of left anterior appendage, even if you have this full assessment of anatomy of the left anterior appendage with CT scan or TEE, you never know what will happen when the procedure. Sometimes it's frustrating, you know that. And for this unique knee-tie 3D folding design distal end, we have this confidence in advancing this device system like Watchman Flex, which is very safe with low wall, inner wall injury. The advantage of this device is not only the minimization of the risk of injury of the cardium, but also the this very exchange of the morphology adapted maximally to the anatomy of left appendage. So if we take a close look at this video, an Ackerman demonstrates stable anchoring even under high distal load. It's open cage structures that accommodates anatomical variation while maintaining strong anchoring. So this controlled symmetric deformation at distal end enhances anatomical compliance, minimizes device movement, and reduces embolization risk during deployment. So for the features of this Ackerman LAC devices, we have a round distal end with unique 3D folding design, keeps the distal end round and safe, with the confidence when advanced and released with ease. Also, we have open cage structure with enhanced adaptation to left anterior appendage anatomy with better device stability. We also have a dense knee-tie frame of fixation anchor, 160 micropet memory, and inlaid threaded inserts with reduced metal exposure, minimized thrombosis. So for this this Ekman device, we have this, it is suitable for multiple anatomies for left atrial appendage, like chicken wing, reverse chicken wing, windsock, bilobed, and cauliflower types. As far as the implantation technique is concerned, we can choose unsheath mode, which is a mainstream and classic approach for placing plug-type closure device, featuring simple release and a short learning curve when the appendage depth is sufficient. We also have the other implantation technique utilizing the safer rounded distal end and open cage design. For this advantage and the retraction mode, it is not only suitable for shallow left atrial appendage, but also for repositioning in case of inappropriate or unsatisfactory of previous implantation. For the sizing recommendation, we have 6 options for these devices, depending on the compression ratio, ostium diameter, and depth of left atrial appendage. So generally, the recommendation of a compression rate is about 10 to 25% in most of the case. So for this impressive product, we performed the safe protective study from 2021 to 2022 in China, enrolled 216 patients randomized either to Ekman or Watchman 2.5. So the TE follow rate is about 85%. So let's see the results. Both the Ekman and the Watchman 2.5 is safe and effectiveness with 98.1% of clinical success rate and 100% occlusion rate. More importantly, we see the excellent performance of no leak less than 3 millimeter is 94.3% in Ekman compared to 84.1% in Watchman 2.5, with statistically significant at 12 months. So let's review the development of the Ekman. First implantation of the Ekman at December 2020 in China, and enrollment completion of Ekman at September of 2021. So we got Chinese FDA approval at January of 2024. And first batch of implantation in China, September 2024. And we got CE mark approval at March 2025, and the first implantation at May 2025. And then let's see what is going on in the near future. Thank you for your attention.
Thank you very much for introducing this technology, and there are clearly different design approaches taken versus 2 other devices we had on the market. So I think that we will discuss the implication for the practical use of the devices after the second talk. So it's my pleasure to invite Krzysztof Milewski to discuss the anatomies of the patients who were screened and treated with this device. Thank you.
Ladies and gentlemen, thank you for inviting me for this interesting session. It's my privilege to present Anchorman in different anatomies and clinical scenarios. So this is my conflict of interest. So I have 3 cases for you. The first case is one-stop pulmonary vein isolation and LAA closure. This is a 79-year-old female with paroxysmal and symptomatic atrial fibrillation in ECHRA class 3. She had CHAD-VASc and Hasbled of 3. And the lady had contraindication to long-term oral anticoagulant therapy due to the previous intracranial hemorrhage. So 2 ultrasound-guided right femoral venous punctures were made. One was for PFA and subsequently LAA device insertion, and one for diagnostic right ventricle electrode placement. So at the beginning of the intervention, we did electrical cardioversion, which restored the sinus rhythm. And then after the transeptal puncture, a pulsed field ablation catheter was advanced subsequently to each pulmonary vein for isolation, with application at ostial and antral position, as can be seen on the movie on the right. And of course, efficacy was confirmed by entrance and exit blocks in all treated veins. So in the next step, we did the TE evaluation of the appendage. So as you can see on the right side, this is single-lobed windsock type LAA with a relatively shallow landing zone. The average diameter made at different angles by TE was between 1.6 to 1.7, but with a maximal depth of 2 centimeters. For this particular case, we selected Anchorman 23. After releasing, we used the standard criteria for device success. We achieved a stable anchoring by duct test. We achieved no peri-device leak. We always try to be perfect of 0, but we accept the result when the leak is less than 3 millimeters. The device compression was excellent, 23%, with a target for this type of device between 10 to 25%. Of course, we confirmed the absence of conflict with the mitral valve, circumflex artery, or the left atrial pulmonary vein. So no procedural complication occurred, and as you can see, the total procedure time took 63 minutes, and for ablation it was 43 minutes. The fluoroscopy time was 16 minutes, a dose area product 6.9, and a contrast use of 30 milliliters. So here is the final TE image. As you can see, especially here, there is a shoulder. So we have a slight oblique position of the anchorman relative to the LAA ostium. However, we achieved very good compression, no residual leak. And we also measured the shoulder. So as you can see here, the distance of the shoulder, the protrusion was 0.4 centimeters. So the result is quite acceptable for us, and we believe that there was a success of device. The second case, which I want to present based on angiography, it's a windsock type LAA with a wide ostium and a small waist due to a ridge, which is on the upper part of the appendage, here below this blue arrow. So for this particular case, we selected the largest device. It's 35 millimeters Anchorman. Here is the implantation technique. So you see the partial release to form a bud flower, so-called bud flower. Once you have the bud flower, you can push the device forward. So we use the combined mode to stably expand the device. The device, as you can see here, let me play the movie, is subjected to local compression and conforms well to the anatomy. We achieved stable anchoring and complete closure. So here in this place, on the left, you see below the blue arrow, the compression. So its advantage of this device, that this device is open cell device. It is very stable, it is conformable, and even if you see that the compression does not transmit into proximal part of the device, and the device remains stable at the ostium. Also, we have 12 hooks that provide excellent anchoring force, regardless of the compression ratio. So I believe that the open cell design, as was mentioned in the previous presentation, is an excellent feature of the device. And the third case, it's a large ostium cauliflower LAA with a relatively flat bilobar configuration and a pouch along the superior rim that you can appreciate here that makes this anatomy challenging. In hepatoclavicular view, the landing zone measure was approximately 28, with a depth of 25. So again, here in this case, we selected the larger device of 35 millimeters. So here you can see that the implantation technique in the details. So the delivery sheath is advanced to the distal portion, a counterclockwise torque is maintained, and the device is deployed by retracting the sheath. And once the device has formed a flower bud, it is gently advanced to achieve the distal anchoring. Finally, the sheath is withdrawn to device marker to allow complete device expansion, and the slight tuck back maneuver is then performed to optimize positioning and ensure complete device expansion, as you can see here. However, on the next slide, you can see that we use slight repositioning. The superior pectinide muscle pouch was fully covered, and the pull test confirmed stable anchoring, and angiography demonstrated an optimal position with no leak. So as you remember, this device has so-called 3D folding design that makes the distal end round and soft. It gives you confidence when you push the device to the distal portion of the appendage with extremely low risk of pericardial effusion. And also this open cell design that was mentioned before, it gives you conformability. It is excellent for complex and large anatomies as shown in these three clinical cases. So let me summarize. Anchorman performed well in all presented complex anatomies, including small ostium windsock, wide ostium LAA with a prominent ridge, and a large bilobar cauliflower LAA. It demonstrated predictable release, secure anchoring, and effective sealing in anatomically challenging LAA morphologies. In the same session, pulmonary vein isolation by PFA followed by immediate anchorman implantation was safe, feasible, and efficient. So in my opinion, anchorman offers a versatile and reproducible option for LLAC in real-world complex anatomies. Thank you for your attention.
Thank you very much. So before we go to the questions from the audience, let's summarize what we already learned about this device. So it's clearly different than the Watchman device because it has open cage, and this distal ends are atraumatic and are folded in a way that adapt to anatomy of the LLA. So this may be the reason that this device may allow implantation, especially in shallow anatomies when the oversizing in the distal part is large, that this force will not transmit along the long axis, and this device will not tend to embolize, to be pushed out of the LLA. Also, this device seems to be shorter, so allow implantation in shallower anatomies. There is some clinical experience, mainly in China. We know this device in Europe for only a couple of months, and we are learning when doing such cases. And there's a variety of anatomies that were already treated. So let me start the discussion by asking you about your strategy. Do you always use the CT scan when you plan the LLA, or what are your criteria for using different types and sizes of the devices?
Well, we prepare or we plan the procedure with usually with a CT scan in almost all the patients. We only go for the TE in cases that the patient has renal dysfunction. But if not, we usually plan with a CT. And of course, it's very important to analyze the anatomy of the appendage, and then to select also the device that you can have in your cath lab according to the anatomy of the patient. Sometimes the appendage is very large. Sometimes the appendage is very small, or the patient is in sinus rhythm or not, and characteristics you have to adapt to the device that you want to use. No, so yeah, I think it's very important to analyze in a better way. I think the CT gives you a little bit more information than the TE. So we usually prefer to go for the TE in most of the cases. Yeah.
So how about China? You routinely use the CT for planning of the procedure, or you go straight to the transesophageal echo?
It is different in different centers. Most of the centers, they use both of the image to assess the anatomy. But some of them, they just use CT scan, or the others use the TE. It just depends on the center or the experience.
Okay, so let us interact with the audience. We have 3 questions. So number 3 is the one that I like. What would you use this device over to other devices? So any comments on that?
Yeah, so I want to start to congratulate Chris for the cases. I was amazed, especially with the second one, with the large channels and the reach. And I think the cases you brought may answer this question, because I think this is a game changer, you know? Because the degree of compression that you have in the reach and the full ceiling that you got at the end, that's for me, it's a game changer. So especially in shallow appendix, and especially in nasty anatomies like this, I think this is a great device.
Okay. And another question, I think very important point, according to the IFU, how many repositions can be done? So it depends whether you do the partial recapture or full recapture, because the way the anchors behave when being deployed is different than the way the anchors work when working with the watchman. So when you do the partial recapture, then multiple repositions are allowed. However, if you do the full recapture of the device, you need to replace the device. So this is I hope the answer. So we will come back to next 2 questions in the next round of the discussion, and I think now it's right time to proceed to the live case. So I'll do that. So this is a case done in Katowice, Poland, in our center, and there's a video. I will walk you through this video and explain what were the consideration during the procedure. This is the group of people working during the case, and this is the team. So let me start the video and make short introduction. Okay. So the patient is 76-year-old male who cannot tolerate the OAC because of the recurrent and massive bleeding from his urethra because of the cancer. He had the cancer removed from the urinary bladder, but then there is a recurrent bleeding when on NOAC, and the patient has AFib and has to be on anticoagulated. So there is a history of coronary artery disease, MI in the past, PCI, type 2 diabetes, hypertension, and obesity. So the patient is obese. Otherwise, he's trying to maintain the normal lifestyle. He has good family support and tries to be as active as possible. So this clinical problem of bleeding, it's clearly impacting his everyday life. Well, so after some discussion and considering that the chemotherapy is planned, and there was no clear reversible cause of the bleeding, according to the treating urologist. We felt that since he cannot be anticoagulated, we need to close the left atrium appendage. From the top of my head, I think that the CHAS-VAS score was 5, and which again makes the patient susceptible for thromboembolic events. So the next step, and I hope to be able to show it in a moment, was to prepare the patients for the case, and the CT was done, and I will show you the anatomy of this patient. Let's start the video, and yeah, this is the where we stopped. So he was on apixaban, which cannot be tolerated. So the hard team discussion, and the decision was to proceed with closure. So the hemoglobin, there's a mild anemia and abnormal renal function. The CHAS-VAS score is 5. So there are clear indications to intervene to prevent the thromboembolic events. So this LAA is highly irregular. So there is a huge difference between the short axis and the long axis. So this was measured in the landing zone, and the depth of the LAA it's around 20 millimeters. So this is a start of our discussion. Maybe
What is the maximum diameter? Because what is
so the minimum diameter was 16, and the maximum was 29. So this is the summary of the clinical problem, and let's proceed to the strategy of the case itself. Okay, so during this case, there is also a minor issue with the transeptal puncture, where we had to use a technique to improve our ability to cross the septum. I will discuss a little bit later. So ultrasound-guided vein puncture, transeptal crossing, and we highly rely on the injection of contrast when doing LLA occlusions. So we still verify from what we see in the computed tomography with what we see in the angiography. So this is device already presented. So there are 4 markers on this delivery sheet, and the distance between first 2 markers is 20. And we were using the double curve, which I think it's standard now. So this PET skirt covers 1/2 of the length of the device, and then at the brim there are anchors, 12 anchors, which provide anchoring of the device. So this is the sizing chart. So we may, given the size of the LLA, we may discuss whether we choose 29 or 32 millimeter device. Also, we need to consider the length of the device. May we have the next? Okay, so again, the video. Okay, this is the puncture. First, under the ultrasound, this is fairly standard approach. Usually, we use proglides. It's probably not a standard in every center. We do this mainly because most of our patients have really high risk of bleeding, and there is a high incidence of frailty, so we do this almost routinely. But of course, figure of 8 may be another option for closing. So approach to transseptal puncture does not really differ from amulet and Watchman devices. We do it in the same manner. Well, this was the point where we couldn't cross the septum, and there was a bit more resistance than usual. So what usually we can do is either use the current, use the electric current to electrify the needle, and what we did was just to improve the pushability of the needle by using the reversed coronary guide wire, and then we easily punctured the septum, and in our hands it's working quite often well. So this is the flashing of the delivery sheath, and again, this is fairly standard procedure. There was a bit of a slack of the septum.
Wojtek, what is your typical place of making this transseptal puncture? Do you routinely use this inferior part? Do you place the, what place is the most optimal, do you think?
Well, we tend to be lower and posterior, or more towards the middle part, not to be too high or too anterior, just to prevent this suboptimal pathway of delivery.
And in your center, most of the procedures were done under the TEE guidance, yes?
Yeah, we don't have the intracardiac echo, and we do under the TOE, and we do not anesthetize those patients. They are not intubated, they are just under conscious sedation. And it works fine for 99% of patients. So, if we may stop for a second. So, this device can be deployed by using two techniques. One is to go deep and unsheath. And the second one is, if you are not really sure which is the optimal landing zone, we can push out, give some contrast, and then deploy. Because this end is atraumatic, it's safe to push in, so we are not afraid of using those two techniques. So it's very different from the first generation of Watchman, which had the potentially sharp ends of the distal cage.
So having this soft tip, I must mention that last time we did the patient with the thrombus inside the appendage, but the thrombus was located very distally. So using this technique of advancement, we placed successfully the Anchorman device. So I think it's also the advantage of the device.
So in this case, you see, there is like there would be difficult to go deeper along the long axis of the appendage because of the angulation. And this landing zone where we implanted the device looks a bit shallow, and we were able to go with the device up to the very end of this first segment of the LAA. So stability check and the routine check with the TOE. We do this stability check looking both at the TOE and on the angio. And the conclusion from the echo was that this device is stable and there is no leak.
What is the amount of the protrusion that you can tolerate? Maybe 1/3 of the device?
Well, we don't want to protrude more than probably than 4.
Okay.
So and we don't want to be too deep again to prevent the thrombus formation. So I think for this case, this technique of pushing out the device and going with this distal fragment of the cage up to the very end of this first segment of the LLA proved to be effective. So this device after 40 days was checked with follow-up echo, and it's stable and there is no leak. So basically this is it. So it's time to answer all other questions and discuss the case. So maybe my co-panelists would comment on what they saw.
You didn't show. I don't know if you do it routinely or not. But how did you measure the LAA pressures before inserting, or does it change?
We don't do it.
You don't.
We don't do it. I don't know. Is it your routine practice?
Well, at least, we check because we are already with the catheter inside the LA, and if it's below 10, we usually give a little bit more volume. Mm-hmm. But because sometimes the patient is very typical, if you recheck or remeasure during the procedure, then you get a different value of that you have get before with the CT. We relied more on the CT. But just when you are in the middle, and the other comment was, finally, which size did you use? Because you were saying that you were between the 29 and the 32 device, because the maximum diameter was 29 and the minimum 16, I think.
Yeah.
So this is also sometimes that when you're in between two sizes, then it can make you to decide.
That's very true.
So in this particular case,
I think it's very valid point that the patient should be hydrated. In this case, the size measured by echo during the procedure was very similar to the size measured by the CT. So we felt that before the CT, the patient was well hydrated, and so in this case we used 29, and we thought about using the larger device, but still the other dimension of this LLA was only 16. So I think it provided successful anchoring and enough of oversize. What is the suggested post-implant drug regimen? So this is a good question. Of course, if the patient can tolerate anticoagulation at least until the first follow-up is done, we maintain patients on anticoagulation. So if the patient cannot tolerate because of the bleeding, well, use of antiplatelet, provokes similar risk, but we use single or double antiplatelet. So for this particular device, it's not mandated by IFU. It's up to the discretion of the physician. So our routine way of handling this is, if the patient can tolerate, we maintain DOAC. If not, we do antiplatelet therapy, unless it's a really active ongoing bleeding, when we have no choice but probably use only heparin. And then after we check for the presence of the device-related thrombus, we just shorten or make it a single antiplatelet therapy and check if the patient can tolerate on this.
And that's related to the last question, which patient do we qualify to LAO in daily practice? And that's it. We started with the contraindication ones,
yeah,
and now we are moving to the high-risk patients. So maybe there are quite a patients that can tolerate a minimum of months of anticoagulation, but most of them cannot. So we need to treat them equally.
No, it's a very, very, very valid question, and I think it's it could be a basis for a session itself to discuss with patients, but definitely those who had, there are new groups of patients that are identified: the renal failure, the patients with after intracerebral hemorrhage, patients who have stroke despite having the DOAC. So I think it's an expanding field. And also another point related to the drug regimen is that it's recommended to use the prevention of infectious endocarditis for 6 months after the implantation. After that, the physician should decide if to expand this prevention or not.
I fully agree that you should look for each patient individually to assess his bleeding risk and his basic indication. For most patients that we have done so far, we are selecting high bleeding patients or patients after intracranial or other GI bleeding, so we'd already put them into higher risk. Then, regardless of the clinical features, we always try to evaluate the procedural features. So for example, if there is absolutely no residual leakage, we believe we can make this antiplatelet or antithrombotic treatment less aggressive. So in many patients, we are giving just a clopidogrel, and then we are trying to do, of course, TEE imaging in the next 6 or 12 weeks, or we are trying more and more to do a CT evaluation to check if there is a peri-device leakage.
Yeah, this topic may not be directly related to this device, but we all love doing the LLA closure, and we like to discuss this. So it's also important to mention that the DRT, the device-related thrombus, is not confined to the first 1 month or 3 months. So there are registries showing that even if you have successful TOE after 40 days or 2 months, there may be a DRT within 1 year, and it's difficult to predict. So theoretically, if we aim to prevent this by using the medications, we should probably continue. But also there are some risk factors for this, like renal failure, like like coagulation abnormalities, but also the deep implantation is one of the risk factors for device-related thrombus. There's one more question: how much should I oversize? So I think it again depends on the implanter. We try to oversize by 20%. So I think at least when reading literature, it's like in Europe we tend to oversize more than in the United States, for example. But it's maybe a result of the first very early experience when there were some tamponades, so people were reluctant to oversize. So we try to oversize significantly.
Yeah, but this feature of the device makes me more confident that I can be a little bit more aggressive, let's say. So I know that there is soft tip, I can push it, there is less risk for pericardial effusion, but also I like this open cell design. It gives the flexibility. I'm also curious, based on our CT follow-up that we are performing in our Anchorman patients, if there will be less leakage around the device. So it is soft, it is gentle device, and it should be well fitted to the LAA anatomy. We'll see it.
So I mean, the purpose of this session is not to tell people which device they should use. It's probably very much operator dependent, but I think with every new device we learn new things, and because the industry tries to create competition, new devices have new features, so I think it's a good opportunity to discuss how different approach in design of the device may influence the procedure. So are there any more questions?
If we come back to your case, if we do it again, which device will you choose after the CT scan or just after the experience of this case? Will you choose like Ambulate or Watchman Flex instead of the?
Well, you know, it's probably, you know, I have much less experience. I have much more experience in using Watchman than Amulet, so probably in a routine practice, this is another option. But you know, I think this type of the LLA could be closed by experienced operator, probably using any available device. So I think maybe I could have used one size larger device. I was, you know, it was early experience, so maybe this tactile feeling and oversize could have been more aggressive, but I think this device is stable and it works. So I think it's an opportunity to learn new things.
I think that there were also two questions. One question was about the rings on the delivery sheet. And if I understand the question correctly, this is like a landmark. So you can, the first ring is on the distance of 20 millimeters, the second 26, and the third is 32. So by placing it under fluoro, you can understand what is the depth of your delivery sheet inside the appendage. Yes, that was the question, as I remember. And the second question was about the anterior chicken wing. But it depends, like in every device in the world, on the side of the puncture, interseptal puncture side, and then to use the delivery sheet and accept more compression. This is the case where we would accept the compression of 25 or even 30%, as I understand.
Probably this is an argument for doing the CT before the case, because you know what you are facing. So I don't see any more unanswered questions. Is there a question from the floor? Well, if not,
let's wrap up.
Yeah. So maybe. Oh, you will. Yeah, it's your job to wrap up.
So this has been a very interesting session. I hope you enjoy it as much as we do. We have learned a lot from the variety of the cases, from small anatomies to big anatomies with rich, nasty cases. And we saw a consistent behavior on the device. Good sealing, secure anchoring, predictable release. So I think we have seen that the Anchorman was a great device. For sure, we need more data on that to really select better the patients and to understand how this device is going to help us in our daily practice. But what we saw today regarding the performance that we saw today was clearly confirming and promising and reproducible. So we thank you, everybody, to be here, and thank all the panelists.
Thank you so much, and thank you for coming and staying with us until late. Thank you.